Based surgeon, Dr. Jamie Schwartz.
Go ahead and get started. Okay, welcome everyone. And Dave, maybe if there are others, maybe there's an opportunity to just send out a text to others and they can join. But we'll go ahead and get started. And I'm so glad that everyone is here today for this update on coronavirus. This is our 13th installment. Hopefully today we'll have some information that's useful for you. After the quick, most kindly Heavenly Father, we thank you again for another beautiful day filled with so many unspoken, unrecognized gifts and blessings. So we just want to pause for a moment to thank you for all of them. Each one on their way, give us the wisdom, the patience, understanding, and allow us to be porous to learn and to share so that we can walk away from this exchange better off, safer, more informed. In your loving name we pray, amen. Okay, so I'm going to go ahead and get started. Again, this is the 13th update. And today we'll obviously go over some trends in California and LA County, just so to go through the numbers with an honest look of the trajectory, where we're going. Are we sort of improving, not improving, moving things in the right direction, etc. Then we'll go over a few questions on news that have been up in the last week or two that may be of interest to you all. That may actually be confusing. And then we'll have time for some open questions if you have any. As I usually start off, I just like to remind people that, again, COVID-19 is a very different virus in the sense that it has a fairly long median of 8 days incubation period. This means someone is not symptomatic, they're not contagious, before becoming contagious, with about 15 to 20% of people having overt symptoms, if you will. And it's because of these two features that makes this a very different virus. It makes it difficult to quarantine or to isolate people because there's some asymptomatic spread. Probably you might hear that people without symptoms don't spread the virus. If someone can mute their phone or their, yeah. So despite what you might hear, thank you, about your, from the news or from various outlets, that if your asymptomatic spread is low, it's just not true. Clearly, if you're more symptomatic, you have more virus and therefore more density to be put into the environment or to expose someone else to. But even folks who are asymptomatic, minimum symptoms can spread the virus and been well documented. So again, I share this with you both to reemphasize that point and also to reemphasize sort of the timelines, right? We're not talking about someone that you may have been exposed to or contacted with inadvertently being at risk for a couple of 3 days, but it actually can last for 2 to 3 weeks or more, okay? The next slide is, again, just reminds us of these two critical times, particularly a period of time of somewhere almost up to a week where even someone who becomes symptomatic, before they became symptomatic, may have actually had 5 to 7 days before that for which they were contagious but had no symptoms whatsoever. So again, asymptomatic spread is important, and you should assume that anyone you're around that you haven't been continuously around is infected until proven otherwise. Not to be paranoid, but to protect yourself and to protect others. Again, spreading is sort of on this continuum of droplet and aerosolization. So it's not a pure aerosolized virus like measles. If it were, we would have had millions and millions and millions of more people infected and dead from this virus. But this is probably more droplet with some aerosolization component, but the majority of this is by far droplet contamination. And therefore, mask is very helpful in reducing the burden of a virus that's actually exposed or expelled into the environment. It's also very helpful in protecting you from others. And more importantly, it's why we say it's so important to use hand hygiene. Hand hygiene is so important. Wiping down surfaces, etc., is so important. Okay, with those brief reminders, let's just get into the data. So I go back to April 6th, now going towards 5 months. Man, it's been almost 5 months that we've been talking about this. We had 16,000 confirmed cases in Los Angeles County and 385 deaths. And now, 5 months later, almost 5 months later, we're at 242,000 confirmed cases. Some of that reflects new and more improved testing, but a lot of it actually is real. And we have just under 6,000 deaths. This, again, I think is extremely important because, again, we have about 10.5 to 11 million people in Los Angeles County. So you can see we still have lots of people who are likely still susceptible. My friends in the Los Angeles County Department of Public Health think that we are no more than 10% of our LA County population who've actually been infected and or significantly exposed. So that means that we have probably 85 to 90% of the population still vulnerable, still susceptible. And if that's the case, including people on this call, that means that we still have the risk of getting infected and should really take this serious about protecting ourselves. At the bottom here, you just see graphs, and these are good news graphs. Even though we've had more and more testing available over time since the beginning of March and April, what you can see clearly is that after that sort of peak that we had in July, these are new cases by day, we've actually seen a slow and steady decline in the number of cases. And this is primarily because we closed bars and in-room dining. I am sure that's a large part of this, just as we saw a large upswell because we opened up things fairly quickly. The number of deaths per day are beginning also to go down as well, where we actually are in these sort of low 40s, if you will. And again, this is sort of important because we were at our lowest point, probably around 28 to 30 deaths in one day, which is a very crude number that's very difficult to inflate. And so being around 40 or 45, while that's a reduction of about 20% to 25%, it's still a significant number of folk in LA County dying each day from this disease. The difference, however, has to do with who's getting the disease. And I'm going to talk about that just for a second. This is California statistics, and I'm sorry it's a little small, but I'll blow. Just how new tests are being reported, we are actually testing many more people, as you can see in this left graph here. So we are doing a lot more testing across the state and the county, which is really, really important. The other portion in this is just what proportion of our tests remains positive. So if I test in any given day, for example, 100,000 people, how many of those tests come back positive? It's just about 5%. This is a really important number because, again, it tells you sort of the rate of infection or spread in our community. At one point, we actually were doing very targeted testing, and 1 out of every 10 to 1 out of every 8 tests came back positive. So some of this reflects that we're testing more broadly, but some of this also reflects that there's slower spread in the community. Again, the full number is just over 1,000 cases that have been reported as positive with 13,000 deaths. That equates to just under 2% case fatality rate. Now, this is something I'm going to come back to in the news because there's been this discussion about, well, maybe we were overcounting anyway. And I'll come back to that because it's been something that's been in the news, and our president's been talking quite a bit about that lately. So I'll come back to that. But overall, the case fatality rate in the state seems to be around 2%, just under 2%, with the highest cases of deaths being in those who are elderly or those with chronic conditions. If you look at the state, it's also very similar in Los Angeles County. We did see a bump in July, the number of people who were hospitalized. That's this graph here. And what you see here is obviously an increase right there, end of June, beginning of July, when we opened up bars and restaurants. And you can see it promptly went down as soon as we shut bars and restaurant, in-room restaurant dining down. The number or the percent of people who are in the hospital who make it to the ICU, at the beginning of all this, in April or so, we were sort of at our first peak. It was about 40%. And now we're around 30 to 31%. So it is true that in the beginning of July or mid of July, people were saying, you know, people just aren't as sick. The people who get COVID and come to the hospital, fewer of them are in the ICU. And it was because we saw younger people getting infected. And you can see this as demarcated in this graph with this sort of dip here, right? But as you can see, that dip was short-lived, and now we're back up to 30 to 32% or so. So don't let the smooth taste fool you. Don't sort of buy into this notion that, well, the sick people who got it, who are going to die from this, actually already got it. And if you're young, the chances of you having a bad outcome is very low. That's just not true. It is lower than someone who might be frail, elderly, or have a bunch of at-risk conditions, but it's not small enough to actually take the risk or gamble. So stay healthy, stay well, and protect yourself and your loved ones. This is just who's getting tested. So about equal proportion of men and women are being tested. And again, you can see the largest age group of being tested is between 18 and 49, almost 2/3. And this is people primarily who are either risk of exposure or they have symptoms. So this reflects people who've been exposed and people who have symptoms. So the majority of people who are actually getting sick now, who are being exposed and have symptoms, are not 65, 70 years of age. It's people who are 18 and 49 years of age. Okay? So our young people are just regular working young people. And I wouldn't even call 49. I don't know if I can call that middle age at my age. But the point is that it's a younger population of individuals who are being exposed and who are actually getting infected and who are being hospitalized. And you can see in California, almost 2/3 of that is represented in our Latino or Latinx community. Okay, so that's reflective of our population. All right. Now, the other part of the news I wanted to share with you is Governor Newsom's new plan for reopening. And as you all know, as I've shared with you before, this conditional plan that he had before was based on sort of 5 different points. And these individual points had to show some pattern over a week. And if you met those sort of targets, if you will, then you would kind of move through different phases. Well, that's been sort of reworked, and Governor Newsom has now published a plan based on risk level, widespread risk level, substantial, moderate, and minimal. This has all been color-coded, and it's defined as the number of new cases, okay? The number of new cases, which is really important, on a given day per 100,000 in the population, okay? As well as the number of positive tests. Now, you are defined at baseline based on what your run-in has been in the 2 weeks leading up to this. And this can be changed based on your data over a 2-week period of time. So whatever your new cases per 100,000 are, whatever your percent positive test rate is, over a 2-week period of time, if you actually are below the threshold for that risk level, your county will be moved into the lower risk level. Now, this is actually important because look at where we start right now. The overall statewide metrics, okay, is that we have a 6% positivity rate. as a 6% positivity rate, that would put us in the substantial category, okay? As you can see, down here in the Southland, okay, we're all still in the widespread, okay, level, which means that the most conservative measures will be taken, not allowing for in-room dining. Many of the sort of salons and a variety of other businesses actually are closed or for business, etc. And essential businesses, quote unquote, are allowed to open. There are a variety of conditions that actually have to be met that will allow some activities and businesses to open while others are closed. And this is actually available on the California Department of Public Health website, the governor's website, etc. And it actually all has to do with the ability of the owner or the business to actually establish mitigating behaviors, such as how long someone's actually in the business, and therefore how long someone may be exposed to someone else or to a member of the staff. Again, trying to keep the staff or the workers safe as well. Again, limiting mixing of people, the size of the environment, the square footage, the footprint, etc. All those sort of mitigating factors are listed here, and which will allow the health departments, the local health departments, to close some and open other businesses depending on their petition to remain open or to reopen. So this is what the new plan looks like. It's a little bit different than before, and it's why you can actually be in different counties and see different behaviors. And this is very, very frustrating because, for example, again, in Orange County, things look very different. Again, the enforcement's up to the local public health agencies. Can look very different in one county versus another county in the same state. Okay. All right. So let me ask a few questions that are related to things in the news. Okay. The first is, that the Center for Disease Control reduce the number of COVID-19 deaths? And as you all may have seen over the last week or so, there was lots of controversy about the CDC. Many of you may know that the CDC each week updates their numbers. And so you can go to the cdc.gov website and you can look at their latest numbers. And most recently, they updated their numbers and modified them so that it was very clear to separate those death certificates and deaths from COVID-19, which were only related to COVID-19 in the death certificate versus everything else. And the intention was to let people know, the public like you and me know, that 94% of people who died with COVID had other coexisting conditions or died from complications like pneumonia, thromboembolism, other things that happen when people are very sick in the hospital. But what brought all of these people to the hospital, what brought all of these patients to the hospital, 100% of them, was COVID-19 infection. So this was actually misinterpreted, tweeted by our president, to say things like, only of all the deaths actually die from COVID. Okay, so instead of 153,000, it was 9,000, meaning that there's all of this conspiracy. And again, as someone who unfortunately has had to sign a number of certificates over my career, the way death certificates are filled out, there is the primary cause of death and the contributing cause of death. And in 6% of these cases, the death certificate was filled out with COVID-19 as the primary cause of death with no other contributing factors. In 94% of the cases, there was a more proximal cause of death, like acute respiratory distress syndrome, number one. COVID-19 may be number two. Sepsis, heart attack, stroke, or cardiopulmonary arrest, right, may be listed as cause number one, but COVID-19 is number two or number three, right? So hopefully that makes sense. This is not a rewriting of history or statistics. This is just a clarification of how many patients who died from COVID-19 actually died from COVID-19 without other mitigating or comorbid conditions. So what this should say to you all, if you're listening, it should be that 1 in 17 people who died from COVID-19 didn't have any other comorbidities. And for me, in a population of 11 million, 10.5, 11 million in Los Angeles County, that means that a lot of people are at risk of being sick and potentially dying of COVID-19, even if they don't have underlying conditions like morbid obesity, diabetes, stroke, cancer, for example, pneumonia, or frail elderly age. So a better way to interpret this is not some conspiracy. It's that 1 out of 17 people who died didn't have all these other comorbidities. The others had comorbidities or other complications listed on their death certificate, but all of them came into the hospital because they had COVID-19 in the first place. I hope that clears that up. The next question, there's been so much about testing. I wanted to address that very quickly. Should I get tested? Well, any test that's actually done should be done with the notion or an idea of what are you going to do with the results. So remember, when you get a test for any disease or any symptom, when you go to the doctor, we should be asking ourselves, why are we getting tested? And if my test comes back positive or negative, what am I going to do differently? That's the rationale for testing. So currently, the reason to test folk really has to do with very limited true things that will change management. If you have classic signs and symptoms, getting tested could be helpful for us to know more about public health, could be more for us to know about maybe isolating people and testing contacts. So from a public health standpoint of view, that could be very valuable. But from a standpoint of view of treating me differently, if I am not severely ill, if I don't need to go to the hospital, then I should self-quarantine anyway, okay? And nothing's really going to be done differently for me if I get a test or I don't get a test. There are really two types of tests that are available, and this is why I wanted to bring this up today. There are what we call molecular tests, and then there are antibody or serological tests. The molecular tests utilize nasopharyngeal swab or sputum from the throat or from the back of the nose. And that actually is a molecular test that uses something called polymerase chain reaction, or PCR. This detects live virus or a virus that looks like COVID-19 or SARS-CoV-2. Not all PCR positive tests means you have SARS-CoV-2. It could mean you have another virus that's very much so like the SARS-CoV-2 virus. So the test is not perfect. It's also false negative that be taken from the throat or from the nose was an inadequate sample, okay? So even testing using molecular tests are not perfect. And in fact, the guy who received the Nobel Peace Prize for coming up with PCR not too many years ago made it very clear that PCR, for a variety of limitations I suggested, really should not be used for diagnosis of infectious disease because of some of the limitations of using a small amount of genetic material, amplifying that, and then inferring from that that you actually have a disease. Nonetheless, this is currently our gold standard, probably better to say our bronze standard for testing for COVID-19. It is a molecular test called a PCR. It's not a blood test. You use a swab from your mouth or from your nose, back of your pharynx, and that's the best test we currently have, which is probably not super reliable these days. The antibody test, which is a serological test, takes a drop of blood, and that test actually tests for antibodies. It does not actually tell you whether you currently have an infection, and it certainly may not necessarily tell you you were previously infected before, particularly if your antibody titer doesn't meet the threshold. Antibody tests as a whole should not be used to detect whether or not someone has the disease present or not. We see a lot of people getting these antibody tests because they're readily available. they're cheap. But again, they probably are not best used for people who have symptoms. They are notoriously negative or false negative, even when people have symptoms. And so they're not reliable to rule out people having disease, particularly if someone is symptomatic. Okay, but again, they're widely available, they're cheap, they don't require the uncomfortable, what I like to call brain biopsy of a swab test. And so people want or like to get that test, but it's actually very, very limited. So all in all, testing should be really limited to people who have symptoms or in certain very high risk conditions or work environments, right? Where you really want to do your best to minimize risk or exposure. Other than that, we should really be limiting tests in general to people who are symptomatic, just as the CDC guidelines suggest. It hasn't stopped people from actually capitalizing on testing during this pandemic. And again, people are making lots of money, throwing lots of tests out there. And so I could talk more about that if you have questions, but I think this is a very challenging issue that we're still plagued with about the appropriate use of testing. This was in the news. It was a good question that kind of came up last week. As you all may know, there has been continued talk about when a vaccine is ready, that we make the vaccine mandatory. There are currently 18 vaccines that are through or at least in phase 1 or phase 2 trials, but there are over 100 pharmaceutical companies, biotech companies, who are investigating vaccines for this. How many vaccines do you actually need? How much money, how much funding are we going to spend on the vaccine, which currently we do not have lots of evidence, even early evidence, that it will be effective. Well, you may have heard Virginia, and Virginia actually has a history, really interesting history in this country, particularly for African Americans. And so I would encourage you all to look up some stuff in the Virginia history, like Bacon's Rebellion, because this might require rebellion in Virginia. Virginia's top health officer, the health commissioner, an African American, actually stood behind a motion to mandate COVID-19 vaccine, and to put this into legislation. And again, a Supreme Court ruling suggested that in crisis, particularly in time of crisis, that a state could do just such a thing. Well, on the 26th of August, the House panel rejected that proposal, but they did not reject it outright because there was a discussion about religious liberty, religious freedom, and that stalled the discussion, which was actually quite nice. But what they simply did is that they tabled this conversation until January of 2021. So this has not been removed from the legislation, it's just been tabled. They will take another vote in January of next year, so you should be keeping your eyes out for this. This is something that will likely happen first in the South, in states like Virginia, et cetera, or what we call the Old South in some ways. And so this is something that's really, really important to just sort of think about, again, how the government is going to actually participate in this pandemic as opposed to leaving it to health experts. So I thought I would actually provide that. And last was a question, I'm sorry it didn't come up, was a question about masks. And there's much talk about masks and why people aren't wearing masks. And I think that this is another opportunity to think about how we, particularly as Christians, can have compassion for others. So this is data that comes from a survey of a representative sample, if you will. And for every 100 people who were surveyed, there was about 20, 1 in 5 people who actually said, I'm not going to wear a mask. I don't want to wear a mask. So thousands of people surveyed, 1 out of 5 refused to wear a mask or did not want to wear a mask, 1 out of 5. And the data here that I'm showing you are the reasons for that one. Now, the largest group, which is about 40% or so, said, you know, it's my right as an American. It's my liberty, my individualism. But that's 40%. The others actually have some pretty important reasons. You could see about 10% say, I don't want to be mistaken for a criminal. This is a big deal. You know, there are people who live in areas where the police and others are just giving, you know, utilizing any excuse to stop, frisk, detain. We saw this in people in stores. For example, people of color going to stores with the mask, right? Another 25% or 20%, I don't have access to a mask. So this becomes resources. So don't assume just because someone isn't wearing a mask that they don't want to, that they're part of this 40%. Maybe they don't even have access to a mask. There are some who feel it's uncomfortable, okay, which is another almost third of individuals. And then there's a small number who have been misinformed, who believe that the whole virus, coronavirus, is a conspiracy. So again, I think this is kind of important. It's not just extremists and individuals, for example, but there are people who actually have reasons that you should consider compassion for. It's one out of every two people that you might see, unless you live in Orange County, that is. I'm just sort of joking. So anyway, I think it's really important to think about this. This is, there's reasons about why people don't want to wear masks, but the other hidden part of this is that 4 out of 5 people do want to wear a mask. So there's news that says so many people don't want to wear masks. Well, at least from this survey, that's not true. 80% of people actually want to wear a mask, actually believe that wearing a mask is the right thing. And then there's another 20% who don't, but half of that 20% don't for actually what for them are actually really good reasons. Okay. So I'm sorry that was out of order, but that was the answer to that question. All right. So I am done with my presentation. I'm going to stop for questions about what I've talked about or other things that you guys might have. Okay.
Okay, Dr. Harrington, I have a couple of questions.
Yeah.
A couple of weeks ago, the feds, they changed the way they're reporting. They said no longer reporting to the, whatever agency they're reporting before, but they report to a different agency.
Yeah.
Did that actually have any effect, or did it, I mean, or what was the reasoning behind that? Or did it have any operational positive or negative effects?
So that's a really good question. And so what David's referring to is this has been something that was a move afoot by the federal government for not just recently, but for probably 2.5 months now, where instead of the states, the local municipalities reporting to the state reporting into CDC, they wanted the local municipalities to report into the state and the state to report to the feds, okay? And so this has been pushed by our current administration for some time. Many have opined about this, and that the rationale for this was to manipulate the data, to control the data, to control the narrative. And that may be true. It's not quite clear that that's the case. If you look at the CDC data, if you look at the graphs, the trajectories, and all that sort of stuff, seemingly are moving along the same paths as they had before. It doesn't seem like there was a big sharp drop off. What has happened, unfortunately, is that some of the interpretations of the narrative of the CDC's data are being misinterpreted, just as we heard over the last week. Only 6% really only died from coronavirus, right? So that's not a manipulation of the data. That's a manipulation of the interpretation of the data, if that makes sense. So far, it seems like if you're someone who really is a numbers person and you're interested in getting numbers, real numbers, those real numbers are still available for you at the county level, at the state level, at the national level, even at CDC. So those numbers still seem to be authentic. What is apparently managed or manipulated to some degree is how we interpret those numbers, right? And so we know that the last week's briefing at the CDC and news conference at the CDC was influenced by the White House. And so what most people have described as an irresponsible interpretation of their latest update, weekly update, was influenced by the White House, right? So I think I showed you that, right? This notion that if you looked at what they said, this is what came out of the CDC specifically. For 6% of the deaths, COVID-19 was the only cause mentioned. For deaths with conditions or causes in addition to COVID-19, on average, there were 2.6 additional conditions or causes per death. Okay, so that's what the CDC wrote. And if you read all of it, it doesn't read the same as weeks before, where they were much more explicit. So you could read this first line and think that only 6% of deaths were from COVID. And that's how our president and others have sort of retweeted and manipulated the interpretation of this. So far, the actual numbers seemingly are legit. It's the interpretation of those numbers which are now, I fear, I think others fear, are going to be manipulated or misinterpreted.
Okay, next question actually had to do the same thing about data, because the state, they had snafu with their data where the lady actually lost her job over it. Yeah.
So the director of health services, my boss, Christina Gali, I talked to her a couple of times a week. Her husband, Mark Gali, who used to work at Los Angeles County, got a job as the Health and Human Services Secretary for the state of California. And he was the person who threw the employee in his office under the bus, okay, so to speak. Maybe I shouldn't say this. This is a public broadcast. Yeah, so he acknowledged that there were problems with reporting, both human error as well as computer processing, that delayed reporting and therefore skewed the numbers. I mean, we had delays in reporting and misreporting of numbers that influenced our reporting in some districts or counties by an order of magnitude. That has been fixed, but for a short period of time, this was really more of a logistics, clerical / technology era, not some conspiracy of someone trying to manipulate something. It's just, unfortunately, what happens. I have, two employers, the UCLA, the medical school, and Los Angeles County. What I can tell you is that my public county employer operates in a different time zone, different bureaucratic, technologic basis than do my folk at UCLA. And that's the same thing at the state. If I think that the Los Angeles County has processes and infrastructure issues, the state's even more challenging. So it would not surprise me that they had technological or basically clerical challenges or problems with their data, that it wasn't beyond it, it wasn't some big conspiracy, and they've since fixed that.
You mentioned about the county reporting, because actually at the college we tried reporting some cases we had, and basically the county said don't bother calling us, because they said that if it's not the same time, same place, and it's 3 or more, that's the only ones they're concerned about. If it's a cluster of 3 or more, it has to be the same time and same place before you call them. Is that the standard?
Yeah, so we're talking about two different things, right? So there's wanting to know that someone's positive, and so actually they want to count every positive. But then there's doing tracers, right? When they actually are going to go back and trace to isolate. And for that, they really need what they call a mini cluster outbreak for that to happen, because they don't have enough resources. So like the Los Angeles Department of Public Health does not have enough public health officers and resources, community workers, to trace every person who's positive. So for example, if I was positive and I called to the Department of Public Health and I said, hey, I'm positive, don't you want to know? They'll go like, no, go to our website. Here's some information. Do you feel sick? Go to the hospital. If you don't feel sick, go to the hospital. Then just stay at home. Here's the website, follow this information. That's what they're gonna say. They wanna know if there are a bunch of other people around me who are positive or sick, because if there are other people, more than 3, so a bunch, more than 3, then that's a threshold to come out, investigate, and see whether or not this may be a mini outbreak, if that makes sense. That's different than actually reporting the positive. So when you call the Department of Public Health, you're calling them because you need information, which most of us at the website, or because you want them to come out and do an investigation. Excuse me, that's very different than the test result. All positive test results, whether they're at a public, commercial, or private laboratory, go into our state test results, all of them. So if you get tested and it's positive, the only way I don't know you're positive or not is if you got a hold of a test kit, for example, you took the test kit home and you tested yourself and it's positive and you don't report that. And that's probably, 1 to 2% of the test out there. Someone has a test kit, it's not under supervision, it's not going to a lab. It's what we call the testing of the affluent or the elite, right? Where someone's doing ongoing surveillance testing and they're given a batch of testing supplies. Usually this is done for serologic testing, not for swabs, but for serologic testing, so blood tests. And someone's given 100 of them so that they can actually do ongoing surveillance for their staff or their employees. And then they say, oh, I got a friend who had symptoms, let me give you a test, right? So it's that sort of thing that certainly is happening. Okay, are there others?
Daryl. This
Yeah.
is Donna. Hi, I
This
came
is-
in late.
this-
I missed. Huh?
This is who? Who is it?
Donna Triggs.
Hi, Donna. Yeah.
Hi. I got the times mixed up, so I came in pretty late. This might be just a general question, but if someone tests positive but they don't have any symptoms, are they just supposed to automatically quarantine themselves for 10 to 14 days, or what?
Well, it depends on. So yeah. So one of the things we talked about earlier, and this is the question that you raise and ask is a really important one, right? Because sometimes it's the only information we get. Someone says, I tested positive. And what I usually do when someone calls me or tells me that or texts me that is I go, let's hold on. First, can you tell me what test you received? What test was positive, right? Because before I can respond, I need to know what test. If you had a molecular test that was positive, then that means that that's a test that's testing for actual virus present right now on that person. And yes, that person should quarantine. That person should go through all the right things that you would, just as if you were symptomatic, right? They should let other people know that they've been around, et cetera, et cetera. Okay. If someone says, no, it wasn't a nasal swab or a oral test, I actually had a blood test. So if it's a blood test, it was an antibody test. And if the antibody test was positive, that can mean almost anything. It can mean you tested positive for another coronavirus that's not COVID-19. It could mean that it was, so that's a false positive. It could mean that you were exposed and you were exposed a month ago or 6 weeks ago, right? Or it could mean that you were exposed a week ago, right? So it's a lot of different things that it can mean. And so for right now, if someone doesn't have symptoms and they have an antibody test that's positive, typically that person still asks, 72 hours, you can go to the CDC, and the Department of Public Health here has a little bit different of a guideline on that. But if you are tested with antibody and it's positive, then the most liberal test is the most liberal recommendation is 72 hours without any symptoms. and then you can go back to, to work or to whatever you're doing. You should still wear a mask, still wash your hands, all the usual things. Okay.
Okay.
But the important question is how are you positive?
Yeah, that's what I want to know. So when you go to these places to get the test done, they're not all using the same technique to determine whether you're positive or whether you should go into quarantine or anything like that?
No, because it depends on who's testing and the question that's being asked, right? So again, there are two general types of tests I mentioned earlier. One is a molecular test where they're using a swab, like a Q-tip. They're putting that in your nose and they're doing a brain biopsy, or they're putting it in your mouth, okay? That will be a test for the virus present right now, detecting current infection. If you get a blood test, that blood test is not testing current infection. It's only testing whether you have previously been infected to either COVID-19, which is SARS-CoV or MERS-CoV-2, or something like that, okay? So it depends on who's testing you and what question is being asked.
So when you go to a site, do you ask them what type of test are you going to give me, or you just go in and whatever they're doing will tell you whether you're positive or negative, then you keep it pushing?
So in general, the current recommendation for the CDC and Department of Public Health for California and Los Angeles County is that they are not routinely testing people who are asymptomatic, period, except for some very high-risk people. So otherwise, they're only testing people who have symptoms. And if you have symptoms, so I'll give you an example. Like I went to the Los Angeles County Department of Public Health website just to see how hard or easy it was to get tested. I put in my information, all the other stuff. I put in that I didn't have any symptoms, but I put in I was a healthcare worker. And I got a schedule for a test the very next day. And the test I didn't go because I didn't want a brain biopsy, but the test I was going to get was a swab, right? The antigen test or the PCR test, right? Which is the one we're talking about for detection. Had I not met the right criteria in the questionnaire, they would not have tested me. They would not have given me an appointment. Okay, so we are only routinely testing. This is routine is operative word. We're only routinely testing people who have symptoms.
Oh, okay.
Otherwise, and we're using the right test. Everyone's using the same right test for that.
Mm-hmm.
Otherwise, surveillance testing that's done like in the bubble for the NBA, right? The NBA is happening in the bubble and they're being tested over and over again with a blood test, with an antibody test for surveillance.
Mm-hmm.
And these are all asymptomatic people, okay? So that's a very different testing strategy for a very different reason. But for you and me, people who are just walking around, unless we have certain sorts of resources, in general, if you have no symptoms and you're not a high-risk worker, you're not going to get tested.
Oh, okay. So
or you shouldn't get tested, I should say. Yeah.
Okay, so don't waste people's time going down there if you don't have any symptoms.
That's correct. There are certain conditions without symptoms where it's recommended you get tested, but there's very limited numbers. On average, if you don't have symptoms, you should not get tested.
Oh, okay. That's lovely to know. Thank you.
Yep. I saw something else in the chat here that came up. Let me see. Are long haulers infectious? Are you talking about Vina? I think that was asked. Let me see. Vina asked that question. I just want some clarification, Vina. Are you talking about like truck drivers, for example, who are crossing state lines and things like that?
No, the long haulers, the people that they're saying are staying sick for months instead of the 2 weeks, but for months.
Okay. Yeah. You're talking. I got you. You're talking about people who have. Yeah. So that's a nickname given to people with what they call a protracted clinical course, protracted clinical course. And so it sort of depends, right? Like we know, and we've seen this in the hospital. I've seen people in the ICU who came in sick with COVID, right? And then they've been sick in the hospital for 5 weeks, but are no longer COVID positive. Okay. Now they're actually having the sequelae, the complications of either other complications, right, or chronic sort of physiologic responses to COVID. And so, yes, it's very possible for people to get sick, to clear the virus, and to still be sick, even sick enough to be in the hospital. There's also people who are COVID positive, shedding the virus, who continue to shed the virus for a prolonged period of time. For the most part, we are not routinely screening people to see that they go from COVID shedding to non-COVID shedding. Most people follow a pretty predictable course. I'm sick, I get better, and when I am better, usually those 10 to 14 days after I'm better, I can be 100% almost sure that I'm no longer infectious, that conservatively speaking. For the person who has some lingering symptoms of that group I just mentioned, maybe they have like a little dry cough or something like that, which happens. You can have a dry cough for 2 months or 3 months after this, right? You can have a little shortness of breath or fatigue for a month after this. Those people are not infectious. If there are real questions about that, they are retesting those individuals. But in general, people with really significant or severe symptoms that get almost completely better, but there are some nagging, prolonged symptoms of a dry cough or fatigue, for example. They're not febrile, right, for example. Those people are, in general, are no longer infectious, okay? There to date has been 2 that we know of confirmed reinfections of COVID-19 from someone with a different virus. So I get infected in April, I get sick, I get better, I go back into the community or whatever, and I get exposed again to a slightly different virus, but you know, because these viruses mutate very slowly, but it's basically, we know it's the same virus, but because we can do DNA sequencing, in this case RNA sequencing, we can tell whether or not it's truly the same virus or whether it's a different virus. And there only been, what we know, we think, 2 cases worldwide of people who've gotten reinfected, okay, with a different virus. So far it looks like we might have some prolonged immunity even when our antibodies, our own antibodies, wane. And this is information that we're still trying to get more information about. So all of that supports this notion that when you get infected and you go through your clinical course, even if you have some residual symptoms for a prolonged period of time, protracted course, if you will, those individuals most commonly are no longer contagious. They're just still having a physiologic response to the residual aspects of the perturbation of their system from an infection, right? So we used to see this a lot. We still see it occasionally with people who have viral syndrome or a flu, and after the flu's gone. They're done with the flu. They have fever, they have cough, they were sick as a dog, right, for a week, they got better, and now they're coughing for 3 months after that. They no longer have the flu, they're no longer infectious, but they're called type 2 pneumocytes, so certain linings, certain cells in the lung have now been sensitized and are very sensitive, and they cough from that, but they no longer have an infection. So it's very true here. In general, people who have protracted symptoms are no longer contagious or infectious. But remember, to be on the safe side, you're now talking about a month to 45 days, right? If you really want to be conservative, anyone who actually becomes newly symptomatic, they might potentially be contagious up to 30 days to 45 days after they become symptomatic. Okay, remember that's the initial graph I showed you. But if you're talking 2-3 months down the line, no, they're not contagious. They're no longer contagious, even if they have some ongoing symptoms. So good question.
Daryl, it's Valerie.
Hey Valerie, happy belated birthday again.
Thank you. So I want to go back to the testing.
Yeah.
So you were saying that they wouldn't test people if they were asymptomatic. Now, what if you have direct exposure to someone?
Yes. Yeah. So again, these are really important questions, common questions that people are asking, right? And so go back to the question that I asked you, right? Which is, I'm exposed to somebody. I don't have any symptoms. I want to get tested. Why do you want to get tested? What are you going to do with the information, right? So that requires you to know something about the virus. You have an incubation period that could last up to 3 weeks. The median is 8 days. So let's just say, Elder Bradford comes home and he's like, honey, I've got the COVID, okay? Now, because you've been around him consistently for day after day after day after day, the chances that you've been exposed to him already is extremely high, right?
Right.
And if you don't have any symptoms, the question I would have for you is, if you were positive, what would you do differently, right?
Mm-hmm.
Nothing, right? You would quarantine yourself just like he's got to quarantine himself. Mm-hmm. The kids would all be quarantined. You'd all assume that you had exposure to someone infected, and because the intimate close contact in the same household, you would assume you have it. That would be the best thing to do, right? If you got tested and they were positive, you wouldn't do anything different. If you got tested and they were negative, I wouldn't believe it. You see what I'm saying? Mm. So, or I could say maybe it was too early, right? So it takes 8 to 21 days before the virus incubates enough, right, to make you test positive. So if Keith got the virus and he came home, he said, I got the virus. Well, he may have gotten the virus 4 days ago, right? Or he may have, it may have got to its threshold incubation point 4 days ago. Now he's got symptoms. And he infected you 5 days ago. So now you go in and you get tested, you test negative, and you test negative because you got tested too early. Does that make sense?
Yes.
Right? So then you start putting in all these permutations. Okay, well, I'll wait a week and then I'll get tested just to be sure, right? So by the time you're doing all of that, if you have no symptoms, the answer is you're not going to change your management. You would still wear a mask, do hand hygiene. You might self-quarantine or minimize the contact that you have with folk, and prolonged contact you have with folk, right? Mm-hmm. And the only reason really to know is if you were someone who had to go to work, right, and you were going to expose other people. Right. That might be a reason for you really to know, because your employer might say, I don't want you here, right? And I don't want you here for 3 days or 7 days or 14 days, whatever their policy is. So as a health worker who's still going to the hospital on most days, if I, came over and spent a couple hours at your place, et cetera, and then, I get a phone call from Keith, and Keith goes, Daryl, I'm sorry, man, I came back positive, right? Mm-hmm. I would immediately self-quarantine. I wouldn't go to work anymore. Even if I felt great, I wouldn't go to work anymore, right? And if I wanted to go back to work, if I really had to go back to work, then I would probably wait 2 weeks and get tested.
Right.
Okay. Right. But otherwise, I'm not going to get tested. I'll just wait it out. If I don't have any symptoms, then I'll know that after a certain period of time, I've been quarantined. I still wear a mask to work. I wash my hands to work. I'm a low-risk person, right?
Mm-hmm. Yeah.
Okay. Well, you finished, Val?
Yeah, I am. Thank you.
Okay. I have a question too. I know of someone whose mother was not feeling well. And it took
Okay.
her a week and a half where she got so weak she couldn't do anything for herself before they decided to get tested. Now,
Okay.
the mother and came back positive for COVID. And the son, he tested the same time as his mother, but he was negative. So she's still in the hospital, and well, of course, nobody knows anything. They're not letting anybody see anybody. But should he get tested again? Because what he was going to do, this was about a week or so ago. So we're talking about a week and a half she was sick. Then he got tested, and then it's a week later. And should he have waited longer than that week to get tested again to see if he has whatever, or just he has no symptoms? He's fine.
Yeah, not really. Again, it's sort of, not to be crude in my response, or oversimplistic. You still go back to the premise of, if he's asymptomatic, what are we going to do about that differently? What would he do differently? So I'm taking care of him, or he's my friend, and he calls me, and his mom is in the hospital and she's sick, and he was around her every day. I would say, you have it, dude. I would say you have it. I don't care whether you're tested negative or positive. I will assume you have it. You're asymptomatic. We're not going to do anything different for you. And if you become symptomatic, I would test you again. But if you're asymptomatic and you're tested negative, I would say you either tested too early, or it was a false negative, one way or the other, or maybe you weren't exposed. But either or, or maybe you weren't really infected. But either or, I'm quarantining you for 2 weeks, right? Period. And the only reason to get retested is if you become symptomatic. Right.
Okay. So
and that retesting is, even if you're symptomatic, if he's young and otherwise healthy, still has very limited utility, because if he's not going to get treated, it's just a statistic that you're reporting in, which is important, but it's not going to change management. He's not going to get any therapy. They're not going to, admit him to the hospital if he's got minimum symptoms, right? But I do think that if someone has a direct or high risk exposure, someone else who's sick, who's in the hospital, becomes positive, that it is important to monitor yourself. Temperature about 56% of the time will be a tip-off, but 40% of the time, no one has a temperature, right? Cough is probably the most common symptom, but you can also get sneezing, like someone who's got allergies or a cold, but usually that's not it by itself. Fatigue, malaise, even, diarrhea or gastrointestinal symptoms, all those things. It's important for us to monitor ourselves. And if something like that happens, then the reason to get tested might be because you really want to watch very closely to lowering your threshold to go to the hospital, right? So, I'm 56, I'm pretty healthy, but I'm in a demographic, that has a higher risk than an 18-year-old or 20-year-old, right? So I might want to, test myself and get treated earlier, not wait till I'm sick as a dog to go in.
Right.
Because what we do know is that there are people who actually get sick and make it through all this, as most people do, but they have residual long-term consequences, right? Some change in their lung function, etc. And so for me, I would really want to be aggressive about therapy. And aggressive about therapy for me doesn't mean going to the hospital and being admitted to the hospital. It means doubling down on the things that we've already talked about that you should be doing to yourselves each day, which is actually good spiritual, mental, and physical self-care, right?
Another part to that is his girlfriend. She's not sick or anything. She has no symptoms. She hasn't been tested, but to be safe, she kept herself away from her mom and the rest of her, like, and her kids. She kept herself away from them. So is that the right thing to do, or should she go get tested also? No, she has
Yeah,
no.
no. I mean, no. I mean, I think that it's all about utility, right? So um, if there's no immediate need or immediacy, like there's not child care, delivery, or something like that, you know, there isn't some reason why she has to be in the immediate vicinity or proximate to the mother or to her boyfriend, the son, then you wait it out. You know, you just there's no reason to do it. And if she were to get tested and we're negative, there's always again the chance of false negatives. Okay. Andy has a question about the quarantine time. If you get exposed to someone who has a known positive, how long should you wait if you're a healthcare worker, etc.? And what I'll say to that is it depends on your institution. So your institution has policies, your infection prevention control people has policies that cannot be more, they can't be more liberal than CDC or the state, but they can be more conservative. So for example, there are certain circumstances where someone has, and let me be very clear, all exposures aren't the same. What do I mean by that? I'm a healthcare worker and I got exposed to somebody, but I was wearing a mask, right? I was only, they were wearing a mask. I was wearing a mask. I was only in the room with them for 5 minutes, right? And it was a very large room. That's considered a very low risk exposure. Does that make sense?
That makes sense.
And what I do with someone with a very low risk exposure is I continue to work. Okay. The CDPH says they define risk of exposures. It's not just any exposure to a positive person. There are different risks of exposure. So did I have proper PPE? Was it a short period of time? Right. That's a low risk versus I had no PPE and I was in the room with them for 5 hours. Very high risk of exposure. Does that make sense?
That makes sense.
And the higher the risk of exposure, the longer the mandatory quarantine.
Gotcha.
Yeah.
Dr. Harrington, I have a question.
Janice. Yep. Hi,
Can
Janice.
you explain, we had 2 employees and they were sick. They were out positive. Both of them were home for a month and they were very sick. No other family members were sick. The other staff were not, were negative. But I don't understand because she says during the time she was having symptoms and didn't feel well, her children were sleeping in her bed. Her husband didn't get it. And it's the same thing with the other employee. No other family member in the house. So how is it that you can be around someone who has it and, you know, it's not spreading, but at the same time, if you're exposed, they're telling you to wear your mask and do this and, you know, do all what we have to do. But yet still there are people who are directly exposed and don't get sick.
Yeah, so it's a really important question, and it has to do a lot with a lot of individual variability and risk, right? So let's bring you back to the conversation we had at the beginning of these, weekly discussions where I talked about different viruses, right? And we talked about something called the R factor, which is something that infectious disease people use to look at the risk of infection or infectivity. So the R factor for COVID is for every one person who's infected, it is efficiently able to infect 2.3 to 2.5 people. Measles, 50. okay, 25 to 50, okay? So you walk in the room with someone who has measles, boom, you got it. Okay, you walk through a room. For COVID, with a R of 2.3, that's in general, and it represents host to host with like susceptibility. So it doesn't take into account the varied susceptibility in the population. Kids, very resilient, number one. Number two, almost all of them asymptomatic. So many of those small kids either won't get it, or if they get it, you have no idea. So her small kids sleeping in the bed with her, etc., either didn't get it, or if they had it, no one knew about it, because this virus isn't really that invasive for the small kids, number one. But we also know that small kids are not efficient vectors of the virus. So that when a kid gets it, it's not very efficient for the kid, 4, 5, 6, 7 years of age, particularly, or smaller, to transmit it to an adult, okay? So that explains the kids. The husband may actually have gotten it, but actually was asymptomatic. It's possible. And if he got tested very early on, it may be a false negative, or because of its infectivity of 2.3 or 2.5, he didn't get it. Now, if she lived in a household of 20 people, 25 adult people, and they all were sleeping in the bed with her, and no one got it, that would be bizarre, right? Because just based on the numbers, I would expect out of 20 or 25 people for her to infect at least 1 or 2 other people, just based on the infectivity ratio, right? So the fact that she has a household of 4 or 5, and it includes her husband and small kids, and no one else is infected, or at least overtly symptomatic, doesn't surprise me at all, okay? If she had her extended relatives, her in-laws living with her, who are older, and they lived in the same household, and they were, say, a set of, say, his in-laws, right? And they were, 60, 70 years of age, etc., with asthma or diabetes, or they were obese, then I would be surprised. But if he's otherwise fairly healthy, and it's just him and kids, I'm not surprised about that. If at your job, no one else got infected, what I would say about that is that you guys are following really good CDC guidelines. People are wearing masks, people are using hand hygiene, right? If you do things properly, it works, right? It actually works, and you can prevent the spread. So that's kudos to you and your team in the office for people wearing masks, for people actually having clean surfaces and washing their hands, etc. Not eating right across the street, right across the counter from somebody, etc., taking those preventive measures. And without knowing other details about the other individual, what I'd say is it's actually not uncommon for people in the household, particularly with small kids, etc., for it not to be everybody, right? But then you do see other people, other circumstances on occasion where the virus runs rapid. And a lot of it has to do with how effective of a spreader the person is and how susceptible the other people are, not just to getting infected, but also getting sick. So I hope that makes sense. That's why, like in a nursing home, it spread through a nursing home, because there were not just so many people who were susceptible, but there were so many people susceptible for complications, right? Versus at a daycare, no one gets sick at a daycare. A lot of susceptible people, but not susceptible for complication. Okay, so daycares are doing fine. It's why elementary schools are allowed in California to go back to school. It's actually the older kids, high schools and colleges, where they actually are still having problems because those people are actually getting sick. They're more effective carriers of the virus, right? So I hope that makes sense.
I just thought, well, it would have been a different virus because this virus is mutating. So I guess if this one infects somebody, it would be a different one to infect the other person. And to make it continuous, because you have sometimes in a family 7, and 3 died. So is it the same virus or is it a different one?
Yeah. No. It's unlikely that the virus mutated that fast in one household over that period of time. It's very unlikely. But it's all about susceptibility of getting it, and susceptibility of having complications. That's what sort of determines, if you look at a cohort or a group of people, how many people actually get it, right? If it was as effective and efficient as people are made out sometimes to believe, instead of having 5 to 10% of the people after 6, 7 months in LA infected, we would have 40, 50%. We'd have almost 80% of the people. We'd already have herd immunity, but it's not as efficient as people think. Like, people make this like really scary. It's not as efficient. This idea that you have to have mandatory masks when you're walking down the street. Yes, go ahead and do it if that's what your city says, so you don't get a ticket or you don't get accosted by somebody, but you're not going to get it walking down the street, right? It's really, as I've said before, duration, right? Density, right? And distance. Those 3 Ds: duration, density, and distance, right?
Okay. Also, Dr. Harrington, wouldn't also the
Yeah.
immune system play into it also? Because I'm thinking if you're building up your immune system, then you're going to be able to fight the disease or any virus, actually.
Yeah, I think that's absolutely right. Like I said, that's a very good point, Pam. I think there are really important individual factors that play into why someone gets this and the other one doesn't, right? That happens in cancer, happens in infectious disease, it happens in heart disease and chronic inflammatory diseases. Same conditions, we're all in the same conditions externally, environmentally, but individually, there's something different about me, or there's something different about you. So I'm glad you brought that up, because that's why I believe that it's so important for us. And Andy said this, I think, last time we were together. She goes, I think I'm going to be like Daryl. I just think I'm not going to get it. And that's the way I feel. Like, from my perspective, there are people who believe that it's eventual. It's at some point you're going to get it. Maybe. But if I don't have to, I'm not. And so me taking care of myself, my family, being cautious, not ridiculously unreasonable, but taking care of myself, taking care of my spiritual, my mental, emotional, and physical self is what I can do for myself, as well as, make smart decisions about where I go and how I go where I go, right? Those are things that I can do. And I do that during flu season, for that matter, So I would say, self-care and how that actually affects our immune system is extremely important. So thank you for that, Pam.
I have another question.
Okay.
Flu season coming up every year, and I usually get a flu shot. The flu shot this year, this is gonna sound crazy. It has nothing to do, or does it have anything to do to help with the immunization against getting COVID-19? Because I have every intention of getting it, but then if I get sick with this flu shot, how am I to know if it's not related to COVID as opposed to just a strain of the flu that they injected in me?
Yeah, so important question. What I would say is, I think that we have to be really careful. Not just saying this to you, I'm saying this to everybody. The media, I don't mean just news media. The media actually is throwing so much information at us that hasn't been vetted, that's not consistent. I do think that there are some irresponsible, maybe even nefarious and malicious folk who are maybe even selfish folk who are involved in administration and leadership in various levels of of not just the country, but state, etc. Because people are people, and people, good, bad, and different are at all rungs of society. Having said that, I don't spend a lot of time in thinking about the conspiracies, the what ifs, etc. I do think that the flu vaccine will be like any other flu vaccine, meaning that they're going to do their best to guess what flu vaccine to develop or make based on sound epidemiological principles. And they're going to develop a vaccine. And we know that flu vaccine saves a lot of lives. If you look at the CDC, and if you actually have the patients, you can go through the flu vaccine data. We know that flu vaccine every year doesn't work the same.
Right.
We know that everyone doesn't necessarily benefit from the flu vaccine, that there are some who benefit more from the flu vaccine than others. Having said that, we know that kids or young people could have the flu, even though there are a fair amount of children who die of the flu. We do know that kids may have a more mild form of the flu, and they can actually infect someone who has a higher risk of having a complication or death from that. So I think that the CDC recommendations related to the flu vaccine and their best efforts to try to do the right thing about the flu vaccine will be unchanged. They're not going to develop a flu vaccine and commingle that with a COVID-19 vaccine. Not only would that be unethical, technologically speaking, it could actually be problematic in terms of complicating the actual administration or the safety of each of the vaccines. So that's not going to happen. At least I don't believe that will happen. I think the flu vaccine will go on as is. I think the bigger challenging question is how will the flu season and people getting the flu, how will that affect COVID-19 surging or not surging? And we don't know. There are lots of thoughts about that in terms of will it be worse or will it be less? And I could talk a lot about that maybe at a different time. But what I would say is that if you're a person who has been identified particularly as someone who's high risk for complications for the flu, you should get the flu vaccine, period.
Okay, what I did, I only got sick once. And that was years ago when I first started taking flu shots on a regular basis. I got real sick from taking that shot. But ever since then, thank God, I've been able to take my shot, my vaccine, and we had a flu shot, and then just keep on, with no symptoms or anything like that.
Yeah.
So
yeah.
there's another question on that too, as far as the flu vaccine is concerned. These are determined, or are they determined like a year or so in advance what flu shot they're going to give on any given year? It's not like something that, okay, in January, in October, November, December, whatever, we're going to give this flu shot. Is it predetermined what shots are being given from year to year?
Yeah, so it's used on rolling data. If you go to cdc.gov and look up influenza, there's actually some FAQs that actually talk a lot about exactly the question that you're asking. In short, really smart epidemiologists and infectious disease people get together and they look at the actual viruses and the family of viruses that are prevalent and are going up and down with regard to their spread and their replication. And then they make a really best guess. They use data, not just in the last year, but they use rolling data over years, rolling data over a number of years to make this season's vaccine. Okay. And it's rolling data. So I would suggest go to CDC. They, sometimes we get it more right than others. Sometimes we get it less right. But they for the type of vaccine it is, they do their best guess at predicting. It would be a very different story if this was a single virus. Influenza is a family of viruses, right? And so if it was even H1N1, it's not just H1N1. There are a number of different types of viruses that make up H1N1, right? So they do their best, to come up, with a vaccine that covers multiple viruses. It's not just one. Multiple influenza viruses are in the vaccine.
Okay. With 45 dismantling that program, that department that Obama put in place, will that have effect on future immunizations as far as we are concerned?
Yeah, it's an important question. I wish I could read into the future, or could render my or would feel comfortable rendering my political views on camera. But all I can say is I don't know. I think that what he dismantled doesn't really directly affect our routine immunization. What he dismantled really has more to deal with disaster response, pandemics, epidemics, and a lot less routine vaccination immunization schedules that are done here in the U.S. There was a question that I saw related to church. I wanted to make sure that I addressed that. If I could, real quick. There was a question about returning, sort of back to this question about safe gathering and effectivity, etc. And I want to make sure that everyone understands that if you are compliant with these 3 Ds, density, duration, and distance, then you can actually have a very low risk activity. I'm going to give you an example. This weekend, LZ got invited to this sort of showcase basketball thing, right? 30 kids in LA County, high school kids, right, from 15 to 18, 19 years of age, were invited to go to sort of exposure, filming, blah, 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 blah. It's like sort of like a good thing. Of course, what I'm saying is how many people are going to be there, how large of a space is going to be, are they going to have their stuff together to make this a safe thing? Well, you had to sign waivers. That just gets them off the hook if anything goes wrong, of course. But the next thing they did screening every day. So, screening of questions. Do you have this? Have you been that? Blah, blah, blah. They took temperatures of everybody each day before you came in. They had mandatory mask wearing 100% of the time. No food was present. They enforced 6 feet apart for the participants, family members, coaches, and all this other stuff. They had hand sanitizer by the gallons. So the players were doing it left and right. The players had to wear masks, et cetera, et cetera. It was all outside, okay? I don't think they could have done any better. I think it was phenomenal. Could you multiply that from 30 kids to 300 kids? I don't know. It's just more moving parts, more people that may be non-compliant that you can't see. The reason why I bring that up is because I think when we start talking about church, it's sort of in between. Let's say you want to start back having church. The density is how many people are in the environment who may unknowingly have infection. So I can reduce that to almost nothing by asking screening questions and by taking temperatures. So if I ask screening questions and anyone who's got a yes, they can't come. So only no's come, and only no's who have a temperature that's less than 100.4. Those individuals come. And you restrict those people who are high risk for complications from being present, right? So I wouldn't take someone who's 85 years old who's on home O2, home oxygen, and say, come to church. Okay? So if you can do that, then the density risk goes way down. The duration, well, I would not have 2-hour, 3-hour church services. You know, normally you would have to adapt to a 45-minute church service, right? Get in, get out, be done with it. And so I would shorten the church service. And then the distance, you just adhere to the 6 feet rule. Even outside, if you can adhere to the 4 to 6 feet rule with everyone mandatory mask, you just created, with those 3 steps, a minimum risk environment, as minimum a risk as you walking down the street in your neighborhood. Okay? In that regard, if you do that, again, not allowing people to eat or drink in a crowd. If they wanted to eat or drink, they'd have to go somewhere to do that. Keeping their mask on, having ample hand hygiene, screening people, etc. Then currently, our public health department in Los Angeles County will allow that church to worship outside without a problem. And they consider that a safe, minimum risk solution or condition. So I hope I answered that question.
I got a question about what
Yes,
is
I appreciate that.
Yeah.
I got a question about outside, because I know last weekend we passed by a restaurant that had a tent set up outside, but it wasn't a tent, it was an enclosed tent. So they're not exposed to the sun, and the amount of air circulation, I think they only had the front open, so they had 3 sides closed.
Yeah.
So is that still?
Yeah. So I mean, you need airflow, right? So if you had 4 sides and a tent and no airflow, that's obviously not good. You know, I've been to outdoor restaurants, and seating is seated apart, but we're all outdoors, and so far, I can't find any wood, so I can't knock on wood. But so far, there haven't been a single report of COVID infection that's been linked to outdoor dining. And so remember, let's think about this. Outdoor dining is still so much more risk, even though it's small, than outdoor church service where you're not allowing food. Outdoor dining, no one has masks on, people are eating and chewing, and you have people mixed, again, from table to table who aren't with each other. Not a single report yet of an outdoor dining source causing COVID infection. So a church service, even if you had a easy up, but you had airflow, people wearing their masks, no risk. I shouldn't say no risk, but minimum risk. I mean, there's nothing that's zero risk, but that should be something that there should be really limited or no concern raised beyond what people would do if they were in their community, for that matter. Again, adhering to physical distancing and mask wearing, as well as hand hygiene.
But does the 3Ds apply to indoor dining? Because they have some restaurants that have indoor dining. I drove past Black Angus this afternoon, and they have a big old sign saying, yes, we're open for indoor dining. And
so indoor dining for Black Angus is on their patio. Okay. So no one is doing currently indoor dining. Like if you go to Cheesecake Factory, you can go to Cheesecake Factory and there'll be a sign that'll say indoor dining, but they won't let you in the restaurant unless you have to go to the bathroom. It's all patio dining. So current in Los Angeles County, different than Orange County, in Los Angeles County, there is no indoor dining allowed unless it is completely open and outdoor, right? So some of these restaurants have a restaurant that becomes an outdoor dining because they open up all the windows, not the windows, but the walls become basically virtual walls. They're open, etc., right? And it's basically a complete open air experience. So people are able to do that. But if you don't have that, it's only patio dining that's allowed currently.
But,
okay, Andy.
Oh, okay, wait a minute. I'm sorry. On the back of that, another restaurant that I went to, I don't know, this was before they did the second shutdown. They did have the 3Ds in place, and we were able to eat inside the restaurant.
Yeah, but so this was before. That doesn't apply now. Like there were when they reopened after April, and they reopened, they allow people to go back to indoor dining as well as bars. So that means people sitting at a bar for 4 hours drinking with no mask on. That's why we got back to our same trouble. So they're not allowing that now. They've learned from their mistakes, from their foolishness, if you will. Andy, you had your hand up.
Yeah, I did for Marky. Here we go.
Okay,
Hey,
okay, go ahead.
I just have a question real quick, and you may have already answered it either in this podcast or another one, but it had to do with like the whole upcoming flu season. So with this flu season coming up and the symptoms being somewhat similar, do you see a way in which medical professionals will be able to differentiate whether or not somebody has the flu or the coronavirus, or are they just going to treat them all as coronavirus patients?
No, so that's a really good question. It's a little bit technical, the answer, but since you're interested in medicine, you know what the heck. So we currently right now have a panel of tests for the flu and for other viruses that I can get back in 30 minutes, okay? So that already exists. So right now, and you have to know that because you can have flu year round, right? It's not, and remember when the coronavirus started, it was in February, right? So, which overlapped with the flu season, remember? So we had in March, I should say in January, February, March, and even a little bit into April, we had overlap of the coronavirus with the flu. And we had no real good testing for coronavirus. But what we did is we had very good testing, called BioFire testing, for the flu and other viruses. And so when you came in with a syndrome that could be flu, could be corona, I tested you with this BioFire assay. And if it came back negative, very reliable, by the way. And if it came back negative, I said you had coronavirus, right? If it came back positive, I treated you for the flu. Simple as that. Okay. Now that we have more coronavirus testing available, what will happen, we'll actually end up testing for both. Because anyone who gets admitted to the hospital, this is in California. If you get to the hospital in California, you will be tested for coronavirus, period. Okay?
Okay.
So that's active testing. That's not like antibody testing. This is molecular testing. Anybody who's admitted will have molecular testing. And they won't admit it back positive. So we'll know if you're positive or negative and where to put you. Okay? So we currently have enough testing now that by the time the flu season really hits us, we'll have enough information to discern or to decide between who has flu, who has coronavirus, or both. Okay.
Okay.
Good question. All right, it's an hour 40. Okay. We have been going. You guys have been asking.
That's because you missed the other week. You playing catch up. You're playing catch up.
Let me see if I have any. Let me see if I have any chat here. No more extra chat. I agree with you, Keith, 100%. All right, so any immediate last burning questions? Otherwise, I'm going to close it out. And in 2 weeks, we'll be back again, God willing, and no lapse in my my mental facilities. Yes.
One burning question for me.
It better be burning. It better be burning. I better be on fire. All right.
If you're tested positive for your symptoms and stuff, and you said you go to the hospital and they admit you, then they do a different type of test. Is it possible?
No, they're not gonna do a different type of test. If you're tested positive, I mean they're gonna do the same test. If you're tested positive and you have symptoms, where you got tested for symptoms was the same test they're gonna do for you in the hospital. It's no different.
Oh, okay.
Yeah.
Because of what you said to the last question about testing for the flu and testing for coronavirus.
No, they may test you for the flu as well, but they will, the coronavirus testing that they will use will be a molecular test, meaning that they'll be testing you to confirm that you actually have COVID-19 coronavirus in your system.
But is it possible to test positive with the regular little test, and then you go in and they do the molecular and determine it's not corona? I mean, is that possible?
Well, remember, there are only two types of tests. There's antibody tests, which test that you got exposed before, and that doesn't test you having current symptoms. And no one, if you have an antibody test, most people with antibody tests no longer have symptoms. So they typically would not, if you have symptoms, they typically would not use an antibody test or rely on an antibody test at all, right? So if you have symptoms and you go to the hospital, they're not going to use an antibody test. They're going to use a molecular-based test, period.
But on that note, you're doing the molecular. Is it possible that you won't have corona, but you'll have something else instead?
No.
Okay.
I mean, it's always possible, but they will act on what's positive, which is COVID-19. It's a chance that it's something else, that there's I don't want to go into this tangent, but there are false positives with the molecular test. But mostly, 95% of the time plus, when it says you actually have COVID positive, you're COVID positive, period. Okay? It's the antibody test which is a problem. Okay? It's the antibody test which is a problem. All right, very good. All right, good. Yeah, you had a lot of good questions.
Thank you.
If there's nothing else burning, I'm going to close things up. I'm going to say thank you all very much for showing up. Let me see. We got a lot of good people here. Yeah, we have a good crowd today. Good. And I appreciate you all hanging in there with all the questions and the answers. I hope it was actually useful. Let's see. Brother Bradford, Elder Bradford, I'd like for you to close us out if you can with a quick prayer. And we will see you all next time. Okay?
All right. Thank you once again, Dr. Harrington, for all the good information that you provided for us. Let us pray.
Yep.
Kind and gracious Holy Father in heaven, Lord, we thank you so much for the privilege and opportunity that we have had to receive this expert insight on the virus and the pandemic that we're currently living in. May we utilize this information, dear Father, as a guidance for our behaviors from this point forward, incorporating it into our lives. We pray for the continuing presence of your Holy Spirit to be with us. Bless us as we depart virtually, and that we may look forward to reunite once again this weekend and lift up your holy name. These blessings we ask in Jesus' name. Amen.
Amen. Thanks so much, Keith. All right, you all. God bless. See you all soon. Take care.
Okay.
All right. Bye-bye.
Thank you. Bye.